Hi, welcome to another series of ASAP Conversations. We've started this series keeping in mind the communities that we work with, the issues that we work on, and especially how the COVID-19 pandemic has impacted these issues, the communities, and especially affected people's access to larger SRHR services and also abortion services. And we have been reaching out to partners in India and across Asia, and today we have guests all the way from Australia. So we're very, very happy to have them, and we're excited to learn from them about the situation there in Australia and what are movements and groups doing about it. So without much more, I just pass it on to my today's guests. And I would start with Brigid. And if you could just give us a bit of an introduction and what do you do?
Hello, and thank you, Nandini, and congratulations. This is such a wonderful initiative, and it's marvellous to be part of it. I'm a nurse, and I've worked most of my career in the provision of sexual and reproductive health and women's health services in the areas of family planning and abortion service provision. South Australia was the first state in Australia to reform abortion legislation in 1969. So conditions were made for abortion to be provided, still in the criminal law, but to be provided with these legal requirements, and so it could be provided in public hospitals. And South Australia has an excellent history of providing public abortion services. But in the last 20 years, really, the limitations of a law written in 1969 for conditions, and expectations of healthcare in 1969 has proven to be completely unworkable. Well, not unworkable because we still work with it, but unacceptable for modern healthcare provision. Provisions of that law are actually exactly the same as the law in the United Kingdom. Women have to be personally examined by 2 doctors. They have to be seen in a prescribed hospital, and they have to have been residents of the state for 2 months. Those provisions where women must be seen in the prescribed hospital and consult with 2 doctors has meant that even as we managed to get early medication abortion available in Australia, that South Australian women have still had to go to prescribed hospitals and generally for 2 visits. Now that's meant that women in the country haven't been able to easily access it from their general practitioner, and also not being able to take up telehealth. So I'm a co-convener of a coalition that is working to decriminalise abortion and have it regulated as healthcare.
So over to you, Suzanne, if you could also introduce yourself and your work a bit.
Yeah. Thank you, Nandini, for inviting us. And we realise as Australians that we float on the edges of Southeast Asia. In fact, I am in Darwin in the Northern Territory, so I'm at the very top of Australia. My closest city would be Dili, which is in East Timor, Indonesia. So I live in the tropical northern part of Australia. My background is that I'm also a nurse and a trained midwife, and worked for many years in women's health, and I have family planning training and did abortion counselling and things like that back in when I was doing clinical work. I've been an academic actually with a special interest in sexual and reproductive health since 2000, I would say. And I did my PhD on unsafe abortion actually on the Thai-Burma border. So a lot of my PhD was documenting and analysing migrant women who had migrated either through forced migration, through trafficking, or a voluntary type of migration into Thailand to work, and then of course needed to have their sexual and reproductive health needs met, but were in very difficult circumstances where their human rights were restricted in multiple ways. So that's kind of my clinical career morphed into my academic interest. Similar to what Brigid was describing, we had early feminists from the family planning movement and also Parliament, a particular one feminist politician who made a law, brought a law into power, making abortion legal if it was done in a particular way, although still criminal. So since 1974, we've had access to surgical abortion in public hospitals, fully paid for through universal healthcare system that we have. However, like Brigid was describing, the law remains static and medicine and social mores advance. And that creates difficulty. And when I was chairperson of family planning, which I was for 11 years, I formed a coalition or collective, whatever you want to call it, of largely feminist women, and some men helped us as well. And we managed over 4.5 years to reform our law, decriminalise it. And in 2017, we got a much better version of the law, although I would argue that the abortion provision in Australia does not require a law to deliver it safely, hygienically, and in a way that is good for women's health.
Thank you so much. Again, thank you so much for setting the context, because I think a lot of our audiences wouldn't know these nuances that both of you bring in. So I think that it was really interesting to learn about the law. Basically, you know, a lot of us wonder if COVID-19 hit us globally, and all the crisis suddenly erupted. But we know that some of it, or most of it, was actually already there. So we want to understand from both of you, and again I'll go, you know, Brigid and then Suzanne, like what was the situation, what was the issues, the challenges that women faced? And as I said, you've already touched upon it a bit, so maybe, you know, if anything has else you want to add to it, especially with the, you know, in relation to access to SRHR and abortion services, you know, if you could let us know a bit on that.
So my best knowledge, of course, is about South Australia, but it might be helpful just to talk about the Australian context, because the provision of sexual and reproductive health services, and most particularly abortion services, has developed in a very strange way in this country, and it remains very unequal. And so until the end of 2017, South Australia and the Northern Territory were in fact the only jurisdictions where abortion services were provided publicly, except to a very small group of very, very marginalised women who managed to get services in public hospitals. In 2017, Queensland decriminalised abortion, and at the same time their government made a commitment and set an expectation for health services that they would provide abortions as public health services. And so that is now being rolled out in Queensland, and women's access in that state is improved because of that. In other states, in the rest of Australia, a provision has essentially been left to the private sector. And although their laws have changed, and Victoria was decriminalised in 2008, the provision remains very much in the private sector. So for women so it's not, you know, the centres aren't necessarily, the service centres aren't necessarily located in areas of need. They're located in areas where, you know, the right profit margin determines that it's a good business model, for example. And so a lot of regional areas aren't well served, and the cost can be completely prohibitive to many, many women. And that has also flowed on to the generalised provision of contraception, particularly LARCs. And so access to getting LARCs, not only information, you know, but getting them inserted, has also been problematic in terms of, you know, the providers trained to do it. And then, of course, there's been this problem with access to abortion services. So COVID has arrived, and we have different problems resulting from that in different states. In our state, in South Australia, we've been advocating for decriminalisation. We were very close to having a bill in the Parliament. It probably would have been there now, if not now, you know, in a few weeks. And we expected, following the law reform, you know, report recommendations, that it would be a bill that would largely regulate abortion in as healthcare, and that then our public services could be supported by general practice and by telehealth, you know, telemedicine abortion. So that's the first thing. It's put that on hold. And then the second thing is that we are still left with exactly the same problem, these problems of access. Country women, instead of being able to do as the government's asking them to do, self-isolate, you know, only, you know, have contact that is necessary, who may then be able to get their abortion at their GP. So there are some general practitioners in rural areas who would be able to provide it, or by telemedicine, using the public service here. That hasn't been able to happen. And, you know, stigma is alive and well. So as soon as, you know, the COVID, you know, unravelled, our coalition was in contact with the Minister for Health, with the Chief Public Health Officer, raising this issue, letting them know that in the United Kingdom, within 48 hours of them, you know, starting to bring in restrictions and telemedicine for healthcare, you know, they had pushed their law aside, done whatever they had to do, and suddenly women in the UK, you know, didn't need to go to a prescribed hospital and could stay with the guidelines of, you know, the social distancing and so forth. And so, you know, in South Australia, despite promises, despite a very broad piece of emergency management legislation being passed, that still has not been used to set aside the provisions in our law so that women can be protected from having to be exposed to infection by travelling. And of course, healthcare providers can be protected from being exposed to this age group, which, as we are being frequently told here in Australia at least, they are the transmitters. So that's, and that's, you know, that is continuing to be our focus of our work these last 4 weeks, and very, very frustrating.
In the Northern Territory, luckily we had our law came through in 2017, and that was very quickly implemented and financially supported by the government in power. We have family planning provides I think something like 80% of all abortions now, something like 70 or 80% of all abortions now in our territory. We're a very tiny jurisdiction, as I said, in population. We only have 1,000 abortions a year, which is, you know, well, you can tell how small we are. And GPs would be providing another amount of medical abortion. And then we have about 5, maybe less than 5, probably 4 hospitals that can do surgical abortion. So that was the situation, and that was, again, all in the public purse under our universal access, our healthcare system called Medicare. I suppose what I had noticed before COVID was that Indigenous women are always treated differently. And so there's a structural element to discrimination. Many Indigenous women live in urban areas, just like everywhere in Australia, but we also have a large proportion who live in very remote communities, which means that they might only have a remote area midwife or a remote area nurse and a locum doctor who is based in a city somewhere else on the phone looking after them. and they have something called like the flying doctor, which I think a lot of people, it's quite famous, where the doctors and nurses go around in airplanes and pick people up and retrieve them if they're very sick. So that was the situation in place. And for Indigenous women, what we notice when we look at the data is they're not really accessing early medical abortions. That is those under up to 9 weeks with tablets. What they are doing is having surgical abortions. So that I can't quite tell if that's a choice on Indigenous women's part. Maybe it provides them more privacy, or we have some guidelines which are not evidence-based, which also say that if a woman is more than 2 hours away from a referral hospital with a gynecological backup, they're not allowed to have, the doctor is not allowed to prescribe the tablets, the abortion tablets. So, you know, in remote health, there already was a structural discrimination around contraception, stigmatization, you know, that already existed. And there was structural differences between poorer women, Indigenous women, and mainstream women, certainly. Should I talk about COVID now? So COVID started to ramp up for us, like around the world, so around March and April, and I think we all anticipated that what would happen here was what we had been seeing in Wuhan and Milan in Italy. And in fact, that isn't what occurred in Australia. We actually did have a relatively rapid public health response. And across Australia, what we saw was that people embraced and abided by the isolation rules that were brought in. And of course, we have the infrastructure to do lots of stuff by telehealth. And we also have a reasonably strong, stable government that made people feel reassured that they would not probably starve on the streets. Like we're seeing in America, I really believe that people, what's causing and driving a lot of that fear there is their lack of a welfare system, a social system that makes them all quite fearful. So in some ways, COVID simply highlighted what was already there. I'm not sure, and the thing like from the Northern Territory, the only one thing, and I haven't heard of this case, but this could happen. What we've all done in Australia is we've closed all of our borders. So we not only have we closed our international borders, but we've also closed our internal borders. And in the past, what that meant was if there was a jurisdiction that didn't allow a woman, say with a later gestation, so in my territory, for example, sometimes our doctors don't have the experience or the expertise to take on a more complex case, or we have conscientious objectors, whatever the reason. And women in the past were flown to other jurisdictions like Queensland or Victoria or New South Wales to get a different sort of abortion, you know, either quicker or on a different sort of legalistic term. Because our internal borders have closed, that is now not possible. And so I don't think we're hearing those cases yet. To be honest, I think that is probably playing out right now. Right. And it's probably, you know, in global terms, they're very small numbers that we're talking about, but if it's happening to you, it's happening to you 100%. So I think there will be some women who have fetal abnormality and all sorts of reasons of why they need the services that they need, and possibly from interstate, and they won't be able to be getting that. We also had a little period of, I think it was a couple of weeks ago, because we're so remote, our supply chains, you know, everything here comes in by trucks or aeroplane, and it takes days literally to get here. So there was a point where we had run very low on mifepristone and misoprostol. And we only have one sort of medication. I won't say the name because I don't want to commercialize it. It's a commercial product. We only have that one product, and we got down to our bare stocks, you know, and a lot of us were thinking, but the truck arrived. Now that was always a problem. We know we're remote, and we live on the end of a supply chain. So those are the types of things that COVID then exacerbated and made us more aware of. But how would we have solved that? We can't magically, you know, manufacture misoprostol or mifepristone. Right. And we can't order it on the web if the aeroplanes are not landing, and the aeroplanes are not landing, you see.
Right, right. So thank you so much. I think I'll just quickly do a little bit of a summarizing for the audiences, and then I'll come back to both of you to, sort of add if you want to. So we were talking about the situation before the pandemic. We've also gone into the situation post-pandemic, and I think some of the very important points that Brigid and Suzanne mentioned is that, even the Australian system, it hasn't kept up with time. Like that's what the biggest takeaway for me is, and it is a big country. Parts of it are extremely remote, and there are issues where of access. There is fragmentation that Brigid had also earlier mentioned, I think, or in one of the emails I remember somebody mentioning the fragmentation of services. So which is where the services are located in a country like Australia, it makes a huge difference, and which leaves out a lot of women, which Suzanne is mentioning. The structural injustices, of course, leave out, treat Indigenous women differently, and probably they get left out the most. So that's a very important takeaway. So the levels of marginalization or the hierarchies of marginalization that exists in societies. So in this situation, abortion services are still available, right? Like even if limited terms, but they are available in Australia, in many parts of Australia.
Well, yes, they are. They are available, although a problem with the supply of PPE
Maybe,
did mean that...
maybe just don't use abbreviation. Sorry to interrupt.
Yeah,
It might be apparent to everyone. Well,
shortages in the supply of the personal protective equipment for healthcare workers to use became a problem for the biggest private provider in Australia, abortion provider. And so they were very close, as Suzanne's described, they were close to not being able to provide early medical abortion because of the medication. The private provider was also in a situation where they were not going to be able to provide because of not being able to create a safe space.
Right.
Suzanne and I are both now members of a national coalition of organisations and individuals advocating for sexual and reproductive health and abortion services around Australia in the context of COVID. And so that was an issue that both that coalition was able to take up some advocacy for, and also our coalition here in South Australia. We wrote to the Federal Health Minister and our Therapeutic Goods Authority to, advocate for those services to receive a priority. That's sorts of things that are getting in the way. I think the other thing that I just would like to put into the picture is on both our coalition here in South Australia and the national coalition does include DV, domestic violence organisations who are very concerned, as are the providers here at our public abortion service. They just are not hearing from women in domestic violence situations. So as you know, it's a very regular part of abortion service provision that you are managing, supporting women who are in situations of reproductive coercion to get the abortion they need. And the workers here at our centre are telling us they're really not hearing from those women, and the domestic violence services likewise are not hearing. So I think as our restrictions lift and those women get access to to be able to be connected to services, that we may well see significant issues, particularly around later gestation presentations, and need for those services quite quickly.
Right. Yeah, thanks for bringing that point up, because there's been a global spike even in the issues of domestic violence and gender-based violence, which is definitely a concern. And as you guys have, both of you mentioned telemedicine, but is it something that is available? That is, like, how often is it used, and what is the situation with that? Because that could be a solution in the interim period.
Well, it can be a solution. Of course, it's not available to South Australian women for abortion because of our legislation. It hasn't been widely used in South Australia. There are some services who are very familiar with its use, particularly services that connect with rural, regional areas. But lots of general practitioners are getting, you know, like they're learning very quickly. But for abortion, it's not available because our legislation, you know, precludes it. But also women in these situations, you know, are not getting access to a private phone call because everybody's locked down in the same house. So the perpetrator is there.
Right.
Yeah.
Suzanne.
In the national coalition that Brigid mentioned, we have been talking about a number of things in sexual and reproductive health, and that is largely in making advocating for supply and making sure that supplies go out to all providers. That's in the way of personal protective equipment, but also the clinical supplies. We've also been talking about reducing some of the probably overly cautious clinical protocols that we have in Australia. So one example is anti-D. In Australia, when you have an early abortion, if a woman has the negative type of blood group, we offer the woman the anti-D injection to make sure that her next baby, her wanted baby, wouldn't get sick. In other countries in the world, this isn't done, and so we're doing evidence-based reviews suggesting that some of these things in the time of COVID be dropped because they're probably not clinically even necessary. They just add in another layer of complexity and anxiety and touch, and you need to actually be physically present, obviously, to give someone an injection. So those are the types of things we're doing at the moment. Telehealth is possible, feasible, and is done in Australia. But of course, as Brigid has pointed out, you need to have privacy and access, and you also need to have a practitioner that's willing to do it. So what we have in Australia is we have a reluctance by many GPs to actually pick up the sexual and reproductive health load. Female GPs are often more willing, you know, they're often trained in women's health, and that they coming at it from that angle. But that's an interesting conversation where we're trying to push some of our GPs to take on procedures, even like inserting LARCs. Many GPs don't want to do it. They see it as time consuming. It doesn't make them money, and it exposes them to a potential indemnity insurance kind of risk. So they're very cautious. They practice a type of a defensive medicine, if you will. Now that's not very good for women in these times. So everything we kind of have thought anyway, or also nurse-led clinics. That's the other thing. You know, if doctors won't do it, and many won't, or don't want to, or can't, we are advocating for nurse-led clinics as well, or for nurse-led procedures, because obviously we understand. Because we read global, you know, the global evidence that the lower you bring it down in the, and I don't mean it in a derogatory way against nurses, but the lower way you bring it down into the health system, the easier it is for women to access. So those types of things that we've been talking about, we were pushing for them anyway. This, if you will, it's even given us a wonderful opportunity to get even more shouty about what we believe in.
So you've got me to my next question, and so very organically we've moved to the the next question, which is about what are the learnings, the big moments from the current situation, because every crisis is also an opportunity, they say. So what is it that we can take away from this crisis, and the big demands to make, the big questions to ask, and so we can sort of move towards making some transformative changes and build a better world. So, again, if I may go alphabetically, I'll start from you, Brigid, and move on to Suzanne.
Look, I think Suzanne is just, has made the point that things that we've been working on for a long time and just not getting an ear, really, because of stigma and because of that minimising of these issues, women's health issues, as Suzanne says, lots of GPs just think, they make a decision that it's too hard, and yet these are things that affect all women for such a significant part of their lives and have such long-term ramifications, both for their physical health, but also for their emotional and mental health. And we know for the health of their whole families. So, you know, they're not really issues that deserve to be minimised, but because of stigma and women's position in society, they continue to be so. And so this opportunity really is like, our lists are already written up. You know, as soon as this happened, you know, we were out with the list. I did an evidence-based literature review in 2010, I think, of not needing anti-D routinely in early medical abortion. There was not a soul who would listen to me. And, you know, really, they just thought I was mad for even talking about it. And yet the evidence was already there and constantly being generated, and we could have been part of generating the evidence. But now people are sitting up, they're listening. The restrictions on our provision of mifepristone in this country absolutely need to be lifted. It's not treated like any other drug of the class of a similar, you know, safety, proven safety level. It's all about stigma. So I think it is the opportunity to say, okay, look, people are listening, let's get these things sorted, and then they'll be sorted forever. Like if we can get those guidelines changed, for example, they'll be changed. So we have to, you know, springboard off those things and say, what can we get? And for our campaign here, our decriminalisation campaign here, for us, we feel, you know, at once despondent because we haven't been able to make a change for women. We haven't been successful in clearing that barrier for women now. But it's another thing that we can absolutely bang on about, as can our supporters, when this problem when our reform bill eventually does get into the Parliament.
Right. Thank you so much. I think very important points again there. And I'd just ask Suzanne to add, and, you know, what do you think are the big asks?
Well, I mean, I think what COVID does is it crystallizes the vision very clearly, and it exposes inequalities and oppressions, and it also goes straight to the weaknesses that whatever society you come from or country you're in, it goes straight to those weaknesses. And we live in a patriarchal society where women are oppressed. And I'm talking about biological women. And that's now what we're seeing is that women's issues of sexual and reproductive health and other people's issues of sexual and reproductive health are always marginalized. And so I think it's just simply brought that into the foreground. I think in Australia, we are fairly agile as activists and academics, and we work well together. Often we form coalitions and work to support each other quickly. So that's taken place.
Thank you to both of you, Brigid and Suzanne, for joining us and for telling us all these very important things, because again, a lot of the times the mainstream media and the news, we don't get to hear a lot about what is going on in Australia, what are the issues, what are the nuances, and you know, because of the way the global information system works. So thank you so much for bringing in these very important perspectives and joining us for the conversation today.